Welcome back to another episode of Beyond the Bedside. I'm Betty Long.
I'm Rebecca Czarkowski.
And we are here to talk about what to expect the next time you head to the emergency room. We hope you don't, but we want you to be aware when you go in. So before we get into this, and I know that you have a lot of experience in the ER as an ER nurse, I want to tee up why we know what to suggest, right? So we've talked about our experience in nursing, but here at Guardian Nurses, what we do is help patients through the healthcare system, right? We walk beside them when they're going to doctors. We visit them in the hospital. So our experience together, as well as our entire team of nurses, have a little bit to say about what to expect in the hospital these days because we see it every day.
Yes, and I think that the more people are aware and you know what to expect and you go prepared, the less frustrating it's going to be for you.
I remember years ago when I was in the critical care units, there was always a hospital tape, like this is Joe's liver, this is Joe. Like when you were having surgery, they teed it up for you so that you could see what to expect when you went to the ICU post surgery. And it was also, sometimes we would walk patients over to the ICUs and their families so they could see what to expect, because there's a lot of noise, bells and whistles, and people and machines and patients in bed with ventilators and breathing tubes. So our point is just kind of, here's what to expect.
So ERs, even when back in the day when I was working in an ER, even back then we had probably 8-hour average wait was like 6 to 8 hours on a shift, and this is going back to early 2000s, mid 2000s, and we've lost a lot of healthcare systems since then. We can start with that. So our ERs are. I have never experienced anything like this. I took my mom. My mom, unfortunately, was in the ER. She was admitted to the hospital and ended up staying. There's a podcast you can listen to from my mom, Miriam Rifkin. And she ended up a little plug, lighting your way. So she spent 3 days as an inpatient in the hallway in an ER.
She wasn't she didn't go up to the floor.
No, and she didn't get a room in the ER. She didn't get a curtain room. It was the hallway right outside the opening doors. Everyone who had to walk to a room in the ER, she was that first hallway bed.
And they considered that an admission?
That was an admission. Because they had no beds at the inn, and she needed to be admitted. It was necessary. She also happened to be across from a behavioral health room, so that room is like a secured lockdown room in case you have anybody who has any suicidal ideations or a threat to themselves or others. So throughout that room gets rotated based on if they're getting admitted or transferred.
Okay.
And so that was our experience for 3 days. But even more amazing than that was for that first night.
I'm not sure amazing is the word, but go ahead.
The first night, they were telling people who were coming into the ER to be seen that there was a 36-hour wait to be seen by a physician.
Oh my God.
So they were on what we used to call divert, but means nothing now. People have to get treated. So people were told and got to make their decision whether or not they wanted to stay or not. I think that's the longest wait personally that I've ever heard of, and it was this year.
Do you think they were saying that to kind of turn people away from their own decision?
No, because you could see the ebb and flow. There was always someone with my mom, and so you could just see the waves of ambulances that nobody can see in the front coming in the back. Some patients didn't meet the acuity or weren't sick enough, and they got put in a wheelchair and taken out front to register and wait with everyone else, while others would have been, critical care or trauma, had to be treated right away, and that just rolls the time out even more.
So talk about that. Talk about what the process is like. So there is a triage. Talk about triage, because I know when you walk in to register and they ask you symptoms, they're in their head or they're making an assessment as to how urgently you need to be seen. Mm-hmm. So talk about that.
So it's we call it ABCs, right? Airway, breathing, circulation is usually what we go through in a triage process. So you might come in with chest pain, And so you don't have any risk factors. You're not on any medication. You're not at an age where maybe that's a risk. So maybe in that ER, there's protocols that the triage team can draw labs, get them started, do an EKG, your vital signs, and make sure that there's nothing there's no active, but they can do all that while you're in the waiting room.
Ah, okay.
Okay, so in an ER where they follow those kind of protocols, most people are getting worked up outside of being in the back where a physician or an NP or a PA or a nurse is actually sitting with you and doing a full head-to-toe assessment. It's a triage that comes in, and we want to make sure that you're safe and you're not going to drop dead. So
don't set the bar too high. Like, really?
Sorry.
Check. You can wait. Okay, you're good.
Because there's things that, like, as a patient, and I can speak for myself, when I'm, sorry to be gross, but like when I had that horrible stomach event in Seattle, I did not stop dry heaving over 24 hours. It was to the point where Betty was like, you got to be seen. You can't keep doing this. And so in a normal ER situation, it happened to be like in the middle of the night. It wasn't quite as busy, but I probably wouldn't have gotten to the back right away. They would have run my blood work, maybe tried an oral medication for the continual dry heaving, maybe do a CAT scan. They might have been able to eke a CAT scan or an ultrasound out if there's no rooms in the back.
While you were in the waiting room.
Dry heaving, right? Because I'm not going to die from dry heaving. They did an EKG. They knew I wasn't having a cardiac event. Okay. They needed to look at blood work and scans. So you can lay in a bed and take up space while you're waiting for all that, or you can be sitting in a chair. They have to somewhat take the emotion out of it. Like, for me, it was the end of the world. It doesn't mean that I'm going to die. I was safe, able to be worked up. But I'm in healthcare, so I know that process. Right. But if I weren't in healthcare or didn't know anyone in healthcare, it would feel as though nobody cared about me. Right? It would feel like I'm as important as that person that just walked in the back perfectly fine. But you have no idea what that EKG, you could be having a massive heart attack and look perfectly normal and nobody would know. You could have someone screaming in the middle of the ER, and this happens all the time, in absolute agony of pain. You will not die from the pain. That is at the end of it all. It's like, it's horrible and it feels inhumane, but you're not going to die.
But I think, and I understand, I understand it from a clinical perspective, but I think one of the problems is that no one's communicating to you sitting there while they're taking the other person in. Rebecca, we're going to get to you in 15 minutes. Or it's just like, go out and sit again, which is what I think we talked about that episode of the
I was just going to say, you were talking about PIT.
Right. And it's like, there's all these people lined up, and to your point, people are walking in front of you, and you're thinking, wait a minute.
Triage nurses tell you, like when I'm triaging someone, I'll say to them, I want to give you a heads up right now. We're working at a 2.5 hour wait. You know, you can't eat, you can't drink. Please be patient. We're not forgetting about you, you know. Okay. And that's kind of the responsibility to be, again, communication. You're absolutely right. If you know what to expect, if I'm saying to you, you're lucky if you only have to wait 6 hours to be seen. So when you're choosing your avenue of care, while it may feel like you don't want to wait to see your PCP for, you know, a sore throat or, you know, something simple, I'm just going to go to the ER because maybe your copay's low, right? Maybe you only have a $50 copay for the ER, so you wouldn't think twice. It's fast, one-stop shopping. They'll do everything. They'll run all the tests for you. It's great. But if you can't afford all that, when do you go to an urgent care? You know, the lack of primary care is definitely another issue within our ERs. So we're closing hospital systems down. So there's a rollout from that. And so in addition to that, you then have lack of care. So maybe you have a full ER of beds. You've got 35 beds in your ER, but 3 of your floors are closed because there's no care. There's nobody to give care. No staff. So that slows down the ER more. There's so many points of failure in the system that create these inefficiencies. And it kind of, where does it start? What comes first? Is it, we know it's an entire system issue, but why do we have that system issue? I don't understand why we even have it. If you let nurses fix it, I'm telling you, it will be solved. I'm telling you.
If nurses could run the world.
If nurses could run the world.
That's our next podcast. So I think we've talked about throughput forever. Even when I was a nursing supervisor, and even now, there's no beds on the floor. Oh, we can't get housekeeping to clean the beds. We have a discharge. It's late discharge. It's the constant. It's never changed. It's like we can't figure this out yet. I don't understand, right? Because to your point, you have to accept patients coming in. Right? You can't just say, sorry, we're full. All seats are taken. Go to the next ER.
And understand, when I was talking about divert's like you close down. If an ER is so busy that they can't possibly see another patient, it used to be that you would pull the switch of divert, which means ambulances shouldn't be coming to your back door. Or I will say, if you're on divert, most other hospitals are going to be on divert too. It's very unusual to have just one hospital. So then they start to just rotate, because you still have to take patients who are calling with emergencies. I don't think back then it felt like the divert kind of just took a little bit of like the pressure off. Like, okay, at least we're not going to get
we can breathe
8 ambulances an hour, right? We're only going to get 2. So it gives you a minute. But I don't even know what it looks like now, because we have in this area, in the Philadelphia and Tri-County area, I'm sure it's everywhere, we've lost a significant number of health systems. So
we've lost health systems. We don't have enough nurses to staff the ER, and physicians.
Right. Yeah.
So the ER may not be your best option for a sore throat or a fever, unless it's a child.
Different story. But that brings up something interesting. You can put comments here too. Children's hospitals and emergency care in children's hospitals, I may be wrong, but I do believe it may be a little bit more efficient, a little bit more timely perhaps, and more collaboration within the care.
What I've heard from our team is more communication, right? So that the staff is communicating with mom and dad, or with the parents, or whomever brings the child in, so they feel like, okay, something, it's somebody's aware that I'm here.
Yes.
Right. And I mean, does Children's Hospital or St. Chris, do they go on divert? I mean, I guess.
I don't know. I don't think I've ever heard of them going on divert, but they could. I don't know.
Well, hopefully there's not that many children going to the emergency room. So aside from chaos, we can expect chaos, but what other suggestions would you share so that would help patients understand, or family members understand, what they're going to face when they get there?
Knowing that you're going to spend hours there, I would tell you, first, med list. You should always have it in your pocket or in your little handbag if you're on any medications, including your vitamins and supplements. You should definitely have your insurance card and ID, a charger. For sure, a charger, because they will not lend you their chargers in an ER because so many have walked, but you're not going to have a phone in your ER because so many have walked. So you're going to want your cell phone and or tablet with a good charger. And I would say, your patience and understanding and recognizing that just because you're waiting in a chair, believe me, nobody is forgetting about you. Or not caring about you. It's just making sure that the sickest are managed first, because they have the highest risk, right, of a bad outcome. And get a primary care physician, because that will be your ticket to avoiding a lot of visits to the ER and urgent care. So that's I know we have a shortage of them too. That's another episode. I think, when we talk about this, it is grace. I think that is what you need to bring with you when you come through the doors of a hospital ER, is just have the slight, I know as sick as, and I've been there, believe me, but people are working really, really hard, and it is not the fault of theirs that there's no staffing, or that there
20
isn't enough
ambulances showed
physicians,
up.
or people sued for years and years and years for everything under the sun, and now physicians practice a lot of, and they need to, defensive medicine, because they need to be able to prove they did right by you. So all those kinds of things that have to occur will also slow down the wheels of delivery. It feels like I'm not giving you really good ideas.
No,
but I think knowing that's what's happening and why it's happening, that it isn't the fault of any one, it isn't the fault of the hospital, the human working in the hospital, the humans that no longer work in hospitals, your insurance company. It's too many people, not enough systems in a profession of healthcare right now that is having struggles recruiting, because it's not sexy anymore. If you're a physician, you're not getting real rich anymore. I can promise you that. Right. As with nursing, but nurses never did. But there used to at least be some kind of a financial incentive to get into healthcare, or the flexibility of schedules. That was a big thing when I started nursing, and you could raise families. And so as an ER nurse there, most of my colleagues at the time, that flexibility of shift work and the time of the day and how many shifts, that's all great. But that's gone now too, because it's like, how do you approve PTO when you don't have enough staff?
Right.
So
and they're not going to hire agency, because we often had agency staff supplement the folks. Yep.
Not budget
Not
friendly.
happening. Not budget neutral.
Neutral.
Budget neutral. Friendly would be a whole different neutral. Yeah. Just get to neutral. So when you think about an ER timing, we joke about the worst days to go to an ER.
Monday morning.
Friday
night.
So if you're sick on Monday morning,
suck it up. No, I'm kidding. But Mondays are really bad, and it used to be Fridays.
Now it's probably every day.
But the Monday backup that starts at about 2 or 3 o'clock in the afternoon was, I wonder if it's the same. It was like a horror show, because you just couldn't move it fast enough to handle the volume and be safe, right? Like we keep saying fast enough and efficient and moving people through, but meanwhile we're talking about people's lives. So you also need to pay attention to details and listen and look, and not just read a monitor or a chart. It's a really tough profession. So I got into emergency medicine, one, because I know I was a really good multitasker, and I have horrible, and I'm not trendy, ADHD. It fed into my energy a lot. I loved knowing the first 25 minutes of every disease process. I loved helping the different patients with different needs, not knowing what's coming through the door. That invigorated me for many, many years. So because I'm a fixer, and it started to feel like I felt again like I was barrier after barrier after barrier. Is I, of course, turned my sights onto how can I do something where it's solution focused.
Okay.
So now at Guardian Nurses, which you can speak to more, it gave me an opportunity to figure out what is the workaround. I just need to get to this. Right. This is the goal I need to get to. And so I now have the support of 60 colleagues that together we can figure out how to get that solution, how to work around the bureaucracy.
Well, and I think that's what attracts a lot of nurses to our role at Guardian Nurses, is that they get to practice the type of nursing that they wanted to, that they can actually work with a patient through to safety, completion, whatever it is, whether it's getting a second opinion, whether it's navigating them through a cancer journey, that they have that time and the resources and the ability, right, the flexibility, if you will, to do what they love.
What needs to be done.
Right, what they love. And they don't have, they have some control of their roster, of their schedule, that they feel empowered, right, to make things happen, to fix things, to be solutions driven. So when we talk about solutions, like you're coming on board because you could find solutions, you could work with patients, you could go with them to the appointment and listen to what the oncologist might be talking about where the patient is deer in the headlights, and you can actually impact their journey, which is really very satisfying to a lot of our team.
Yes.
You can go into the hospital and you can work with the clinical team to say, hey, my patient doesn't really understand what's going on, or says no one has been in to see him in 2 days. So can we get a team meeting together and talk about it? So you have the power, I guess, the not authority, but the power, because you're working for the patient, to have those things done, and that really makes a difference to patients. Well, we can't get them moved up in the ER necessarily, perhaps, but we can help their journey much more effectively than if they were just doing it by themselves. So here's the question we always get. So what's the busiest day in the ER?
The day after Thanksgiving. The worst.
The worst.
The worst.
And why?
So it's the day after a holiday. People on Thanksgiving late night will drop their old elderly loved ones off sometimes so they can have I'm being honest, respite.
You're kidding.
No, I'm not. I'm not kidding you. People eat a lot on Thanksgiving. There's a lot of family stress. There's a lot of sports stress if you're from that group. A lot of drinking, and people get sick.
Yeah.
You know, it is just, and it is a long day. It feels like the longest day of the year.
Okay. So
sure.
I hear locally in our area, the best time to go to the ER is when?
During an Eagles game,
Exactly,
of course.
exactly.
Nobody goes to get care during an Eagles game. Honest to God, it is the funniest thing. Thank God. I mean, you could see every game you wanted to see, and then, I mean, like floodgates opening right afterwards. And there's always a heart attack.
Right.
Always at least one heart attack comes in. It's like, oh my God,
Does it
we're
matter
crazy.
if they win or lose?
No, they're just like, it's horrible. I shouldn't laugh. The Eagles game, anytime the Eagles are on, you can go to an ER and you will you will receive care promptly.
That's right. So only get sick during the fall and winter.
Yeah, through February. Go Birds.
Go Birds. So thank you for that. That's a great tutorial. Hopefully it helped you. If, God forbid, you have to go to the emergency room, call Rebecca.
Yeah, tip your bartender.
We'll be here all week. Thanks for listening to another episode of Beyond the Bedside. We'll see you soon.
Bye.